I am afraid it might kill me in my sleep. I have heard that when you take it, some people don't wake up. I have heard that it makes you dependent. And this went on and on for 2 years until he finally accepted when he got to the point where he was barely sleeping 2 hours a night. Welcome to your daily health briefing. I'm Dr. Albert Takem. This show is here to help you navigate the complex U.S. medical system, one step at a time. Whether you are decoding a new diagnosis, fighting for a referral, or just trying to stay informed, you are in the right place. Let's get into the science. Many patients are surprised when I tell them that insomnia is very treatable and should not be ignored. Many patients have spent their life sleeping 4 to 5 hours a night because they are afraid of treatment of insomnia. Today, I want us to dive into this topic with a sleep medicine specialist, Dr. Naveed Shah, because I know too many patients walking around with just 4 hours of sleep and afraid of insomnia medications. Dr. Shah, welcome back.
Thank you.
So, I want to tell you about this patient of mine. He's 71 years old, has been dealing with insomnia for over 10 years. And the previous 2 years, every time I tried to tell him, take something for insomnia, he would resist. We started with, I am afraid it might kill me in my sleep. I have heard that when you take it, some people don't wake up. I have heard that it makes you dependent. And this went on and on for 2 years until he finally accepted when he got to the point where he was barely sleeping 2 hours a night and started taking Zopiclone. And now he sleeps 8-9 hours every night. He's so thankful and cannot go without that pill. Now, why do you think insomnia is so misunderstood?
So insomnia, I think at one point everyone has experienced some form of insomnia.
Especially if you've been to medical school.
I think it's part of medical school.
It's really part of medical school to have insomnia.
But large swaths of the United States, obviously in the world, everybody is experiencing insomnia in some form or another. Mm-hmm. Most of the insomnia is limited, self-limited, and will go away. But there's a lot of people who, due to their job, their work, their stress, anxiety, depression, these kind of things, their insomnia kind of takes more precedence, and it's a little bit difficult or harder to treat. Some people have traumatic events in their lives, and the insomnia kind of starts there. Some people just have internalized things and insomnia. So there's many ways to acquire insomnia, whether it's short-term or long-term.
So let me interject just 1 second and dive straight into the science. What is insomnia?
Yeah.
What does it actually mean?
Well, insomnia means that for a certain period of time, you're not sleeping a certain amount of time. Mm-hmm. And that's really what insomnia is. When you're supposed to be sleeping, you're not sleeping. Mm-hmm. Either you have what's called sleep onset insomnia, where you can't sleep as you get into bed and you're trying to get to sleep, or you get to sleep, but then you wake up in the middle of the night. A lot of people, maybe they're on diuretics or they have to go to the bathroom at night, and so they wake up, go to the bathroom, then they can't fall asleep. Mm-hmm. Or some people have stress in their lives and they just cannot fall asleep, or they fall asleep but then wake up. Mm-hmm. They wake up very early and then they can't fall back asleep. Mm-hmm. Or some people are up and down all night. Mm-hmm. There's several forms of insomnia.
Okay.
So basically the gist is that you're not sleeping when you're supposed to be sleeping. And you're supposed to get about 7 hours plus or minus of sleep.
Again, if you did not go to medical school. If you did, it's a lot less than that.
Right. Exactly. So there's two processes that actually govern sleep. Mm-hmm. One is what we call the circadian rhythm. Mm-hmm. In other words, this is where your melatonin kind of spikes at certain points and it decreases at certain points. Mm-hmm. And there's a second process that is called the homeostasis process. And that's not governed by the melatonin is governed more by the adenosine, the ATP, basically, and so the byproducts of ATP actually, which is your
the
energy
molecules
of the mitochondria, kind of build up in your system, and they build up to a point, and the melatonin and circadian rhythm build up, and that is what helps you to kind of determine your sleep time.
Okay.
And that helps you fall asleep. If one of these processes is off, then we have to figure out which process it is. For example, the adenosine type of it, if you're drinking coffee looks like adenosine molecule. And so you can kind of mess up the homeostasis part of that sleep drive. And so obviously we would get rid of the coffee, but that's one issue. Or the melatonin, for example, if you're on your phone at night, any light is going to decrease your melatonin. And so that process is going to be thwarted, right? And so you're handicapped with one process.
Okay.
So that is one reason that you would have insomnia. Again, stress is a big one. You know, some people they internalize a lot of what am I going to do the next day? And that is cortisol.
Hello.
Yeah. And that's cortisol, right? That's your stress hormone. And a lot of these people, they can...
I think that's the primary reason for my insomnia.
Yeah.
Is thinking, oh my God, what happened?
What's going to happen
What's
tomorrow?
going to happen tomorrow?
Right.
What if the internet shuts down in the office?
Yeah. So those are things that are beyond your control, but you are obsessing about them.
Yeah.
And then, you also have, nowadays, the phone is probably, I would say, the number one cause of insomnia.
Really?
Yeah. That light enters your cones and rods, which are in your, eyes, and that's going to your back of your head, your hypothalamus, and it basically dysregulating your sleep. Because it's blocking your melatonin, it's increasing your dopamine, right? And so it's increasing cortisol. It's doing things that people are not realizing and it's becoming, because of dopamine, becoming addictive as well. So we need to get rid of the phones a couple hours at least before bedtime. Just like you shouldn't be eating 3 hours or so before bed. You should not have that phone. If you have insomnia, that phone has to go.
If you have insomnia, that phone has to go.
Yeah. Now, if you don't have insomnia, you should also get rid of the phone. But if you have insomnia, obviously, then that's going to be something that's not going to be helpful in any way. Some people leave the TV on. They may have a timer for their TV. Again, the TV is not a good thing. This is all part of what we call sleep hygiene. Because that really feeds into insomnia as well. And so sleep hygiene would be keep, the room dark. The darker the room, the better the melatonin. Keep it cool. If you keep it too hot, you're not going to be sleeping also. Keeping it cool. Making sure that, the bed itself is comfortable, the area is safe, those kind of things. So that's all. And you're sleeping when you're supposed to be sleeping. In other words, there are people who are night owls who sleep later and then they function fine. There are early people who go to bed earlier and if they function that way. So knowing yourself is also part of it. But then there are people who do know themselves but still kind of, for example, you're going out at night on a Friday night, you would expect to be sleepy the next day. But then if you have to go to work, now you're creating what's called sleep debt. It's almost like a credit card. There's compound interest. So if you're shrinking your sleep time, for example, you're working at night, you come home, and now you have to take your kids to the school, you have to cook, whatever, and then you're going to sleep, but then you have to go back to work. Now you're shrinking your time of sleep. So the decrease in sleep time is actually a risk factor for early morbidity and mortality as well.
Wow. So decreasing your sleep time increases your chances of diseases and death.
And death. Absolutely.
Wow.
Absolutely.
So let's dive into the treatments of insomnia. And what does modern medicine have to offer?
Right. I think there are several ways that we can approach insomnia.
Mm-hmm.
What we like to often get is a sleep diary of several weeks of how you're sleeping, how you're not sleeping, when you're sleeping, when you're not sleeping. Are you taking naps? Are you not taking naps? How long are those naps? And what are the times of those naps? In other words, if you're napping, you're sitting on the couch at 7 p.m. and you're napping 2 hours, you're not going to get up and then go to bed and then fall right back to sleep. If you are, then there's other issues going on.
Mm-hmm.
So if you have insomnia, you have to know when you're going to bed, when you're getting up. And not just when you're getting up in the morning, but how many times are you getting up?
Mm-hmm.
So that sleep diary is very important.
Okay.
All right. So that's number one. Once we know what your sleep diary looks like, now we can say, okay, you have an issue with going to bed later,
Mm-hmm.
but then you fall asleep and you're sleeping the rest of the night.
Okay.
That could be a circadian rhythm issue.
Mm-hmm.
And so we can try to use melatonin to bring the circadian rhythm back.
Mm-hmm.
There's other people who can fall asleep, but then 3 hours later, they're waking up.
Mm-hmm.
That may be an issue of cortisol spiking early.
Mm-hmm.
Normally, cortisol will spike around 6, 7, 8 in the morning, somewhere around there. And that is a signal for you to wake up.
Mm-hmm.
But in some people, you'll have it at 3 in the morning, at 2 in the morning. One of the reasons is sleep apnea. In other words, when you stop breathing and your cortisol shoots up, you're going to wake up a lot of times.
Okay.
So cortisol is a wake-up hormone. So then we're looking at cortisol and ways to decrease your cortisol.
Okay.
There are other factors. Again, there's psychophysiologic insomnia where an event happened and now you can't get rid of that event, but it plays out and you can't sleep. So sleep diary,
Mm-hmm.
make sure sleep hygiene is where it should be.
Okay.
Are you drinking caffeinated drinks? Because that's going to get rid of the homeostasis. Are you doing something to your melatonin, in other words, a phone?
Mm-hmm.
Is there a cortisol spike
Mm-hmm.
earlier than not? So these are the main actors.
Sleep hygiene, number one.
Correct.
And how about medications?
Yeah. So medications, I would say, is second or third tier.
Okay.
In other words, let's figure out why you're not sleeping and let's attack that rather than we give you a sleep medicine. Now, the sleep medicine.
Well, actually, you
Yeah.
make an interesting point there. I meant to ask you, in the role when someone has insomnia,
Yeah.
is there any role for a sleep study?
So pure insomnia, a sleep study is not indicated.
Mm-hmm.
Insomnia with sleep apnea symptoms,
Mm-hmm.
sleep study is indicated.
Okay.
In other words, if you're snoring and you're tired during the day and you're, waking up several times and people are saying you're pausing in your sleep or gasping or choking, then sleep study is indicated.
Okay.
But there's a lot of people who just have insomnia who don't have sleep apnea symptoms, then it's not typically indicated
Okay.
for a sleep study. Yeah.
Study.
But what as a sleep specialist, we like to tackle the cause and the root rather than medications initially.
So what we should be doing as primary care physicians is referring patients dealing with insomnia to a sleep specialist.
Yeah, exactly. Because a lot of people, it's easy to take a medication. For example, you mentioned Lunesta, right? So that's one of the benzodiazepine type of medications. They work on what's called GABA receptors in your brain.
Mhm.
They actually don't induce sleep, but they induce a lighter form. In other words, people who take those medications, they do fall asleep, but they have lighter sleep. They don't get the deeper sleep also.
Mhm.
And so they're physically sleeping, but they're not reaping the benefits as much of that sleep as they could.
So the sleep is not as restorative as it should be.
It should be. Right.
So
There's certain ways if, somebody's like out of their mind and they really need something, I'll give them something for a short period of time.
Mhm.
In the meantime, I'll work it out with the sleep diary, the sleep hygiene. What is it? Is it the homeostasis process? Is it a melatonin issue? Is it a cortisol issue? Is it a lot of stress? Are you depressed? Is there or you have heart failure? Do you have some severe chronic disease? Do you have neuromuscular issues? So there's other reasons to have this insomnia, and to kind of find that reason. And the medication then plays a good secondary role. The number one treatment for most insomnia is cognitive behavior therapy. The problem with cognitive behavior therapy is that it takes time. It takes kind of an effort. It takes a little up and down, where people just want something in our society, a pill, get me to sleep, and that's the end of it. So that's not the end of it, because it's, again, part of several processes that are happening
At the same time.
And we need to delineate what is it, what is the what is the first, what is the second, what is the third issue that you're having, and then go after those issues. If I just give you a pill, I'm not doing my job as a sleep specialist.
Wow. I did not realize how much of a deeper dive needs to go into sleeping.
Yeah.
I think I'm going to be your first patient. All right. Well, it's been a pleasure, Dr. Shah. So as we wrap up, we just need to leave the patients with a few action items. So number one, insomnia could just be a minor problem, or it could signify something deeper. Number two, you need a deeper sleep evaluation with a sleep medicine specialist.
Correct.
And number three, taking a pill for insomnia is not necessarily the right thing to do right away.
Correct.
It is a stepwise approach. There is a stepwise approach to the treatment of insomnia.
Absolutely. Absolutely. Yes.
Okay. Fantastic. That's why we love specialists in medicine. We never stop learning.
Thank you.
Thank you, Dr. Shah.
Yeah, thank you.
This has been the Daily Brief. Medicine is not about certainty. It is about responsibility. Decisions are often made with incomplete information, but they are always made with your safety in mind. In a system that can feel rushed and fragmented, you deserve clarity, continuity, and an advocate who sees the whole picture. I am Dr. Albert Takem, your physician ally, high-level science, human-level care. I will see you at the next briefing, or I will see you in the clinic.